Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice case of hemangioblastoma showing some unusual morphologic features. So this is a case of a 34-year-old male patient who presented with ataxia and on imaging was found to have a large posterior fossa solid and cystic mass with flow voids. And this is an excellent clue to the diagnosis of hemangioblastoma on radiology. So he underwent preoperative embolization in order to minimize the vascularity of the tumor. And as you can see here from the low power magnification, we have a highly vascular tumor with tumor cells or stromal cells growing in between. Now, in some areas, and actually most of the tumor examined under the microscope did not show this a peculiar or a very characteristic morphology. Instead, it showed this like sheath-like growth pattern. And to the first instance, I thought whether this is really a hemangioblastoma or some other differential diagnosis. However, the tumor cells exhibited some acidophilic cytoplasm, but also this vacuolated cytoplasm. And again, more of the same in some other areas, more like solid growth pattern or sheets of tumor cells with this vacuolated, very characteristic vacuolated cytoplasm, minimal really atypia. Look at this one with the beautiful vacuolated cytoplasm, slight atypia, and really not much on the way of mitosis. And again, another focus with some tendency to arrange itself, the tumor cells arrange themselves around vessels, but also this very beautiful vacuolated cytoplasm and some tumor cells with acidophilic cytoplasm, and then some degree of pleomorphism, not really much in the way of pleomorphism. Only occasional, very occasional mitotic figures could be identified. What was really interesting is that besides the areas of solid growth pattern, there were large areas of necrosis, and here more also of the necrosis. And really this brings into other tumors like, for example, GPM into the differential diagnosis. And by immunohistochemistry, the working diagnosis was whether this is hemangioblastoma, as was suggested by the radiological appearances, or because of the solid growth pattern, and because of the necrosis, whether this is something else like a glial tumor, glioblastoma in particular. So the tumor cells beautifully positive for Inhibin, alpha inhibin in the stromal cells in the areas showing the more typical growth pattern, but even in the solid areas, strong positivity for Inhibin in support that this is hemangioblastoma rather than another tumor. And even the areas of necrosis, this is the necrotic area, and these are the sheets of tumor cells, and again showing the positive cytoplasmic staining. Now, NSE also was beautifully positive both in the areas with the typical, more typical growth pattern where we have the tumor cells growing in nests or in small groups separated by the vasculature, or more so in the solid areas around the areas of necrosis. So Inhibin and NSE strong supporter to the diagnosis of hemangioblastoma rather than a glioblastoma. D240 is also described in hemangioblastoma. This was focally positive in this tumor. In this example, many areas were completely negative. This was around the area of necrosis, and the positivity is clear here in the tumor cells. And this was again the area of the more typical growth pattern where we have the groups of tumor cells separated by the vessels, and this is also positive. Now CD10 was negative, and this is needed to rule out the other important differential diagnosis, renal cell carcinoma, because of the association of hemangioblastoma with the von Hippel-Lindau syndrome and the possibility of metastatic renal cell carcinoma. Remember that the tumor had this unusual appearances. This is why carcinoma, metastatic carcinoma, had to be ruled out. GFAP was completely negative, as was cytoplasm cytokeratin. So in a way, essentially ruling out glioblastoma as well as metastatic carcinoma. Now, because of the abnormal or unusual morphologic features, I performed P53. It showed mosaic staining pattern. So this is non-mutant. This is not abnormal. This is the wild type or the normal staining pattern. And the Ki-67 was slightly elevated, but put together, if we put everything together, this would be consistent with hemangioblastoma CNS WHO grade 1. The morphology, especially focally, is consistent. Now remember that hemangioblastoma can show, actually it is described to show some solid growth pattern, as was in this case, which was quite unusual to me. This is the first time I encountered the solid growth pattern in hemangioblastoma. There was the areas of necrosis, and probably this is related to the embolization that was performed preoperatively in order to try to minimize the vasculature and the hemorrhage that might occur during surgery. Now, Ki-67 was slightly elevated. Again, probably this is related, like a reaction or substitution to the death or necrosis induced by embolization. However, there were no evidence, no morphological features apart from the necrosis. The mitotic figure was accepted, and in areas the tumor showed the typical growth pattern, as was the immunohistochemical staining pattern, with positivity for alpha inhibin, for NSE, and focally for D240, that would support the diagnosis of hemangioblastoma in correlation, importantly, with the radiological findings. I hope you find this tip useful in your daily practice. Thank you.